Usually when we talk about a medical diagnosis, or especially cancer surgery, there's this expectation of like absolute precision.
Oh, absolutely. Like it's a math equation.
Right, like engineering. You have a
Yeah.
bad thing inside you, the scan shows the exact borders of that bad thing, and the surgeon just points and says, well, we will cut exactly here, and then you are cured.
Broken or not broken.
Exactly. Cancerous or not cancerous, we want it to be clean.
Yeah.
But as you join us for this deep dive today, we are stepping into the world of gynecological oncology, and specifically dealing with chronic skin conditions.
And suddenly that precision instrument feels like it's completely broken.
Yeah, we are looking at a surgical and diagnostic landscape that is just incredibly murky, and the stakes for the patients navigating it are, well, they're incredibly high.
It really challenges the very foundation of how we define a cure.
Uh,
Today we're looking at vulvar squamous cell carcinoma,
mhm.
or VSCC. Specifically, the type that arises from a chronic inflammatory skin condition called lichen sclerosus. We're combining international gynecological oncology guidelines, pathological data on genetic mutations, and treatment protocols from patient support networks.
All to answer one really highly specific question.
Right. What are the recommended oncological surgical margins when resecting this specific type of cancer? I mean, how much tissue actually needs to be removed to ensure the disease is gone without, destroying the patient's quality of life?
And to even approach that question, we really have to look at the brutal reality of this disease, right? And how it's been treated historically.
Yeah, it's a tough history.
Because for decades, the logic was just straightforward. Cancer is deadly, so cut out as much tissue as humanly possible to ensure it doesn't come back.
Which makes sense in theory, but
But the vulva is a highly sensitive, anatomically complex area. So this radical approach routinely left patients with severe psychosexual morbidity, loss of basic bodily functions, and physical complications like lymphedema.
which is awful. That's a chronic, painful swelling of the legs caused by removing lymph nodes and all that surrounding tissue.
Right. And the standard that drove that radical surgery was the pursuit of an 8 mm pathological margin.
Yeah, the old gold standard. Guidelines recommended that when a surgeon removes this cancer, the pathologist looking at that removed tissue under a microscope, they need to see at least 8 millimeters of completely healthy cancer-free tissue surrounding the tumor on all sides.
Which, I mean, 8 mm doesn't sound like much if you're just glancing at a ruler.
It sounds tiny.
Right. But the physical reality in the operating room is completely different. To get an 8 mm pathological margin on a microscope slide, a surgeon actually has to remove like 15 to 20 millimeters of tissue from the patient.
Up to 2 full centimeters.
Yeah. Why is there such a massive difference between what the surgeon cuts and what the pathologist sees?
Well, we have to look at the physics of tissue preservation to really understand that discrepancy.
Yeah.
When a surgeon removes human tissue, it doesn't just stay the same size.
Right, it's alive. It changes.
Exactly. It gets placed in a chemical called formalin to preserve it for the pathology lab. And formalin works by causing protein cross-linking and severe cellular dehydration.
So it dries it out.
Intensely.
Yeah.
The tissue literally seizes up and shrinks. So a surgeon might cut a 15 millimeter margin of healthy tissue, but by the time the formalin dehydrates it and the pathologist measures it on a slide, it has shrunk down to 7 millimeters.
Wow. So they took almost double the tissue, but they still officially failed to get the 8 mm margin.
Exactly. They get a report back saying the margin is inadequate, even though they took a massive amount of tissue.
It's like a tailor trying to cut a piece of silk fabric, right? But the fabric violently shrinks the second the scissors make a cut.
That's a great way to think about it.
The tailor has to just hack off a massive piece from the bolt just to guarantee they end up with a usable garment. And in the context of vulvar surgery, taking an extra centimeter or two of tissue, it has devastating consequences.
Truly devastating. Because between 25 and 37% of these tumors are located dangerously close to midline structures.
We are talking about the clitoris, the urethra, the anus.
Right. Taking a wide margin in these areas means the patient might lose the ability to urinate normally or retain bowel control or ever experience sexual pleasure again.
Which is just a horrific trade-off. And the human cost of that 8 mm rule forced the medical community to finally look at the data again, didn't it?
It did. Retrospective studies started coming out, including a really major one by Tegrutenhuis and colleagues. They analyzed patients who had narrower margins to see if they actually fared worse.
And what did they find?
The findings showed that a pathological margin of just greater than 2 millimeters or greater than 3 millimeters did not appear to increase the risk of the local invasive cancer returning.
2 or 3 millimeters instead of 8? That is a massive shift.
It is. The European Society of Gynecological Oncology, or ESGO, actually updated their guidelines to state that narrower margins are acceptable, specifically to preserve those crucial midline structures.
Okay, but wait. I have to push back here because if the data shows that taking 2 millimeters is just as safe for survival as taking 8 millimeters, why is the local recurrence rate for this cancer still stubbornly hovering around 40%?
That is the million-dollar question.
I mean, if you're listening to this and wondering how a surgery can be deemed successful if 4 out of 10 patients get cancer again, it just doesn't add up. If the margin distance around the invasive tumor isn't the problem, what is the surgeon missing?
You're missing the soil.
The soil.
Yes. When the cancer comes back in these patients, it isn't usually the original tumor returning because the surgeon didn't cut wide enough. It's actually a brand new tumor growing in the surrounding tissue. This introduces a concept called field cancerization.
Field cancerization. Okay, so we are shifting focus away from the invasive tumor entirely.
We have to, because about 70% of vulvar squamous cell carcinoma is associated with lichen sclerosus.
Wow, 70%.
Yeah. Furthermore, 85% of stage 1 VSCC is associated with a precursor lesion called differentiated vulvar intraepithelial neoplasia, or DVIN for short, and/or lichen sclerosus.
Right.
These two conditions are the field. They are the soil from which the tumors sprout.
Let's ground this in the biology of lichen sclerosus for a second, because the clinical definitions get a bit heavy. The sources describe LS as a chronic autoimmune inflammatory dermatosis. Essentially, the body is attacking its own skin, right?
Yes. Specifically, it attacks a protein in the very deepest layer of the skin, the basement layer.
The basement layer. Okay.
The immune system targets this protein, causing a massive, relentless buildup of inflammation deep down within the tissue architecture.
So think of a busted water pipe in the basement of a building.
Like that.
The flooding starts at that bottom layer and just soaks upward, completely ruining the structural integrity of the floors above it. With lichen sclerosus, the skin thickens, it tears, and it scars because that deep inflammation has basically destroyed all the elasticity.
Exactly. And while that chronic inflammation is flooding the tissue, it's causing immense cellular stress. Over years, this relentless cycle of damage and repair leads to genetic mutations in the skin cells.
So the skin looks fine on top, but it's sick underneath.
Right. The surrounding skin might look completely normal or just slightly scarred to the naked eye of the surgeon under those bright operating lights. But microscopically, it's a diseased, genetically mutated field.
So when a recurrence happens, a second field tumor is simply sprouting from the lichen sclerosus or the DVIN that was left behind after the first surgery.
Precisely.
It's like, imagine you meticulously pull a weed out of your garden. You dig deep, you get the entire root, you do a flawless job.
At the soil.
Right, the entire patch of soil around that weed is already seeded with dozens more invisible weed seeds. You removed the immediate threat, but the environment is primed to grow another one.
And the data in our sources backs this up powerfully. 72% of invasive recurrences happened in patients who had these precursor lesions present at their surgical margins.
72%. That statistic really forces a complete reevaluation of our priorities, doesn't it?
It changes everything. The real margin we need to worry about isn't just the physical distance from the invasive tumor.
Yeah.
The critical margin is the precursor margin. Are we leaving behind a precancerous field?
But if that mutated soil is invisible to the naked eye, a surgeon can't just look at the tissue and know where to cut. How do they actually identify where the dangerous field ends and the healthy tissue begins?
They rely on the pathologists. The pathologists are now looking for specific genetic markers at the cellular level. And the most critical tool in this evaluation is p53 immunohistochemistry.
Okay, the p53 gene. That comes up constantly in oncology. For those who maybe haven't taken a biology class recently, how does p53 actually dictate whether a cell becomes cancerous?
Well, p53 is frequently called the guardian of the genome.
The guardian, okay.
Yeah, it's a tumor suppressor gene. In a healthy body, every time a cell divides, p53 acts as a quality control inspector. If a cell has mutated or damaged DNA, p53 stops the cell from dividing and forces it to repair the DNA.
And if it can't be repaired?
If the DNA can't be repaired, p53 triggers apoptosis, which is programmed cell death. It basically forces the damaged cell to self-destruct so the mutation cannot spread.
But in the environment of lichen sclerosus, with that busted water pipe of inflammation constantly damaging the cells, the p53 gene itself eventually mutates.
Right. The guardian is asleep. The inspector leaves the factory line.
Wow.
When the TP53 gene mutates, cells with damaged DNA are allowed to divide uncontrollably, which is the very definition of cancer.
So how do they spot this asleep guardian?
Pathologists can take the tissue from the edge of the surgical margin, apply a special chemical stain that's the immunohistochemistry, and literally see under the microscope if the cells have this abnormal mutated p53 protein.
And the clinical studies linking this mutation to patient outcomes are just staggering. One study demonstrated that if a patient has DVN, or simply this abnormal p53 staining at their surgical margin, their recurrence rate skyrockets to 75%.
It's massive. Compare that to patients whose margins are clear of these precursors. If there is no DVN and normal p53 function at the margin, the recurrence rate drops to 33%.
A 75% chance of the cancer returning versus a 33% chance, that creates a really huge dilemma for the surgeon. I mean, picture a doctor getting a lab report back days after the surgery.
Right.
The report says the invasive cancer is completely gone with a safe 3 mm margin, but the tissue at the edge of that margin is positive for p53 mutations. What do they do?
Well, the European Society of Gynecological Oncology guidelines address this directly. They state that if a patient has DVN or these mutations at the margin, the surgeon should consider going back in for a more superficial resection.
Meaning a second surgery.
Yes. They recommend taking the patient back to the operating room to shave off the top layers of the skin where that mutated field extends.
Okay, the guidelines say consider it, but the reality on the ground tells a completely different story.
Yeah, very different story.
A survey of Canadian gynecologic oncologists revealed that only 11% would actually take a patient back to the operating room just for residual DVN at the margin.
Only 11%.
If we know leaving this mutated skin behind causes a 75% recurrence rate, why on earth are 89% of doctors refusing to go back and remove it?
You really have to look at who is lying on the operating table. The patients facing HPV-independent vulvar cancer arising from lichen sclerosus are predominantly elderly women, frequently in their 70s or 80s.
Right. They aren't healthy 20-somethings.
Exactly. They carry a host of other comorbidities, cardiovascular disease, diabetes, compromised immune systems. You're talking about putting an 80-year-old woman under general anesthesia for a second time in a matter of weeks.
And performing a second surgery on tissue that is already ravaged by chronic inflammation. I mean, the vascularization, the blood flow required to heal a wound, it's already terrible in skin affected by lichen sclerosus.
Exactly. A second resection in that area often leads to catastrophic wound breakdown. The surgical site simply falls apart and refuses to heal.
Oh, that's terrible.
It leaves the patient with an open wound, severe pain, and high risk of systemic infection. The morbidity of attempting to surgically clear that invisible field often outweighs the statistical risk of monitoring the disease.
So if surgery is completely off the table for clearing this mutated soil, doctors have to find a way to neutralize the field without using a scalpel. They need a medical solution that suppresses the inflammation and stops the cycle of mutation.
Well, we have one. The gold standard medical treatment for neutralizing this field is ultrapotent topical corticosteroids, or TCS.
Right.
Clobetasol propionate is the most common agent used. And the beauty is, it isn't a targeted billion-dollar genetic therapy. It's a highly potent, readily available steroid ointment.
But handing an 80-year-old patient a tube of steroid ointment and telling her to just apply it is not a protocol.
No, not at all.
The research, specifically the clinical application guidelines outlined by specialists like Dr. Jill Kraft, shows that the physical mechanics of how the medication is applied determine whether it actually stops the mutations.
The medication has to reach the basement layer of the skin, where the immune system is actively attacking the proteins. Applying it to the surface does absolutely nothing if it can't penetrate the thickened, scarred architecture of the lichen sclerosus.
So how do they get it down there?
The protocol dictates that patients must first soak the area for 15 to 20 minutes in warm water.
Okay, so that soaking hydrates the tissue, opens the pores, and softens the hardened skin, creating a pathway for the medication.
Exactly. Once the skin is patted dry, the patient applies a pea-sized amount of the steroid. And the vehicle of the medication is paramount here. It must be an ointment, not a cream.
Why not a cream? Creams seem easier.
Because creams are formulated with alcohol bases. And because lichen sclerosus causes microtears in the tissue, applying alcohol feels like pouring acid on an open wound.
Oh, wow. Ouch.
Right. The intense burning causes patients to immediately abandon the treatment.
That makes total sense. So they use the pea-sized amount of ointment, and then they have to physically massage it into the skin for up to 2 minutes. It cannot be lightly swiped on like a daily moisturizer.
No, the mechanical action of rubbing, forces the steroid down through the tissue layers until it reaches that basement membrane.
And once it gets there,
Once the steroid reaches that layer, it suppresses the local immune response. It shuts off the inflammation. And by stopping the inflammation, it stops the cellular damage that forces the p53 gene to mutate.
that's incredible, but there's a catch, right?
There is. The most challenging aspect of this protocol for patients is that it never ends. After the active inflammation is controlled, the patient transitions to a maintenance schedule, typically twice a week,
Yeah.
and that maintenance is lifelong.
Lifelong. Even if the skin looks completely normal, feels elastic again, and the patient has zero symptoms. Because the underlying autoimmune disease is still there. The pipe in the basement still has the potential to leak. If the patient stops the steroid, the immune system resumes its attack, the inflammation floods back, the genetic field becomes unstable, and the risk of a second cancer sprouting from that soil skyrockets.
The continuous use of the steroid is what prevents the progression from inflammation to precancer and from precancer to invasive carcinoma.
Which brings us to a really shocking paradox in the sources. Knowing that the steroid stops cancer from forming, a survey conducted in the Netherlands and published in the VU Research Portal exposed a deeply concerning gap in clinical practice.
Yeah, this part is frustrating. The researchers analyzed the prescribing habits of gynecologic oncologists treating these specific patients.
The findings in that survey highlight a massive blind spot in postoperative care.
Oncologists prescribe topical corticosteroids less frequently to patients who have just undergone surgery for lichen sclerosus-associated cancer than they do to patients who only have lichen sclerosus and have never developed a tumor.
I mean, let that sink in for a second. The patients at the absolute highest risk of the cancer returning, the ones whose tissue has already proven it can mutate and grow a tumor, are the ones least likely to receive the preventative medical treatment that stops the soil from mutating again.
It's backwards. But the surgical intervention seems to create tunnel vision. After a resection, the local anatomy is heavily altered by scarring, making the classic visual signs of lichen sclerosus much harder to identify.
Right.
Surgeons and oncologists become hyper-focused on monitoring the surgical margins for invasive recurrence, and in doing so, they completely lose sight of the underlying dermatological disease driving the entire process.
There's also a significant psychological barrier to lifelong steroid use, shared by both patients and general practitioners. The widespread fear is that applying a highly potent steroid to delicate mucosal tissue for decades will cause the skin to atrophy, to thin out and waste away.
And skin atrophy is a valid concern with potent steroids, generally speaking. But context is everything here. Dr. Jill Craft's work tackles this fear by explaining the structural reality of skin affected by lichen sclerosus.
Right. Think of it less like delicate tissue paper and more like a thick, cracked concrete sidewalk.
Exactly.
The skin is tearing and bleeding not because it's fragile and thin, but because the chronic inflammation has replaced healthy, elastic tissue with rigid fibrosis. It has zero pliability left.
The topical steroid does not thin healthy skin into tissue paper. It reduces the inflammatory infiltrate within that concrete-like tissue, allowing the body to clear the fibrosis so the area can actually regenerate soft, elastic skin.
It's healing it, not destroying it.
Right. When the protocol is followed correctly, using only a pea-sized amount massaged in on a twice-weekly maintenance schedule, the risk of harmful skin atrophy is statistically minimal. The benefit, however, is the prevention of a 75% cancer recurrence risk.
This entirely redefines the concept of a successful cancer treatment. The goalposts have completely moved.
The parameters of success in gynecological oncology regarding this specific pathway are fundamentally changing.
Let's draw all these threads together for a moment. When we look at the surgical treatment of vulvar squamous cell carcinoma arising from lichen sclerosus, the recommended oncological surgical margins for the invasive tumor itself are actually shrinking.
Yeah.
The historical dogma of cutting an 8 mm pathological margin, which, as we discussed, required amputating massive amounts of healthy tissue, is being replaced. Data shows that clearing the invasive tumor with a 2 or 3 mm margin preserves the patient's anatomy, protects their midline structures, and crucially, does not compromise their survival from that specific tumor.
Because the focus of the danger has shifted from the visible invasive margin to the invisible precursor margin. The persistent long-term threat to the patient's life is leaving behind a field of tissue plagued by DVN and p53 mutations. Because clearing that entire mutated field surgically would cause horrific, unacceptable morbidity in elderly patients, the burden of a cure shifts from the operating room to the patient's own bathroom. It relies on the rigorous, lifelong application of ultra-potent topical corticosteroids to chemically neutralize the mutating soil.
And the shift from a purely surgical mindset to a medical one leaves us with a profound realization about the future of oncology. I mean, for over a century, the paradigm of cancer treatment has been dominated by the physical extraction of a bad thing.
Right, the engineer's mindset.
Yeah. We viewed a cure as an event. A surgeon cuts it out, the margins are clear, and the event is over. But as we map the genetic field of our tissues and understand how chronic inflammation drives mutation, we are entering a totally new era.
An era where surviving cancer is a lifelong biological partnership. It forces us to ask, as our understanding of field cancerization evolves, are we prepared for a medical system where the most critical intervention in preventing a cancer recurrence isn't a scalpel wielded by a surgeon, but a warm bath and a pea-sized drop of ointment applied diligently by the patient at home?
We really just want the clean binary scan showing the bad thing is gone. We want the surgeon to simply point and say, I got it all. But the biological reality is infinitely more complex, demanding a level of ongoing participation from you, the patient, that we are only just beginning to fully understand.
It's a journey.
It really is. Thank you for joining us on this journey into the complexities of human healing. We love navigating these murky waters with you and finding the clarity hidden deep in the research. Until next time, keep questioning, keep learning, and keep looking beneath the surface.